Hi, my name is Mary Vukicevic, and this is part one of the surgical management of cataract presentation. I'd like to acknowledge that this presentation is based on content created by Jane Farley. So in part one of this presentation, you will understand the orthoptist's role in cataract management. You'll gain a basic understanding of intraocular lens formulae, and you'll also learn about the types of intraocular lenses available. In part two, which is in a different video, you will be given an overview of the cataract surgery technique and learn about the potential operative and post-operative complications that a patient may face. And all of these topics are very important because orthoptists are very, very much involved in cataract surgery pre and post-operatively. Now, before you go further, it's really important that you have some assumed prior knowledge that I'll be expecting from you. So I will be expecting that you completely understand the anatomy and physiology of the lens, that you have a thorough understanding of the pathological processes that lead to cataract formation, that you know the cause or the etiology of cataracts and what sort of symptoms patients experience when they have it. And I'll also be expecting that you have a thorough knowledge of the different types of cataract that a patient can present with. So I've listed them there: nuclear, cortical, subcapsular, and that's divided into anterior and posterior, traumatic, and congenital. Now, if you don't have a good knowledge of what I've just explained there now, stop this video and do some revision. All right, let's have a look first at the orthoptist's role in cataract surgery. Orthoptists are involved both in the pre and post-operative cataract assessment, and in addition to that, some orthoptists also are involved in surgical assisting. When you go out on your clinical placements, you'll definitely see patients with cataract and how the orthoptist is integrated into that care plan. The first step in any pre-operative cataract assessment is a thorough history taking and also an understanding of the patient's chief complaint. And this includes the type of symptom that they have, for how long they've had it, and so on. So, for example, they might complain of blurred vision and halos when driving at night, and it might be that they've had this for the past 6 months, and it's a slowly deteriorating condition. You also need to ask them things like what their hobbies are. So, for example, their hobbies might be reading, or their hobbies might be wrestling or sport or something like that. Now, their hobbies are important because they're the things that they're doing every day, and they're the things that are definitely going to be impacted if they have any ocular disease, particularly cataract. It's a good idea also to ask patients what their occupation is. So, for example, a patient who's a truck driver that drives at night time is definitely going to be affected by cataract because it can cause halos and light flare of an evening when driving. They might do a lot of computer work. They might be a painter. All these things matter. So you might think, oh, it doesn't really matter to ask what do I care about what the patient's occupation is. But it does matter in terms of their quality of life and day-to-day living. Past ocular history is also very important that you find out about that and take thorough notes. So you have to ask patients things like, have you ever had any laser to the eyes? So if they've previously had laser surgery, that's going to impact on your intraocular lens calculations. You also need to ask them if they've had any accidents or injury or other surgery to their eyes. I've had patients that have come in and I've asked, have you ever had any type of eye surgery? And they say no, but I have a look at the eye and I can see that there's an intraocular lens in place in one eye, but they've got a cataract in the other eye. And they've just not thought to say that they've had a cataract removed in one eye. So be very, very careful about proper history taking. You also have to ask them whether they have or have ever had any eye conditions or disorders. For example, have they ever had a retinal detachment? Have they had a vitrectomy with silicone oil? Have they had a corneal graft or previous cataract surgery? All these things can impact on the type of cataract surgery they will have in the future if they need it. If they've previously had cataract surgery in one eye, you should ask them who with and where, so that we have a bit of context around that. And it's a good idea then to find out the current intraocular lens type to try and match it to the second eye. And knowing who did the surgery helps you to find that information, because you might have to ring that clinic or contact that clinic somehow. Asking a patient about contact lenses is also important, because that leads you into a discussion about whether they've ever tried monovision. And I'll talk a bit more about monovision after. Also, if they're a low myope, asking them questions about do they read with their glasses on or off, because that can also impact on the refractive aim later. So in terms of the orthoptic pre-operative investigations, here's a list of very common things that you'll do, if not all of them. So you'll perform unaided visual acuity, a photometry, to find out what sort of glasses prescription they have and record how old the glasses are. You'll then perform vision with correction, and that might be with glasses or contact lenses. A subjective refraction is important at this stage, and best corrected visual acuity. Also, information about ocular dominance can be important, especially if the patient is going to aim for monovision down the track. Intraocular pressure is commonly performed pre-operatively, and then you've got your biometry or your A scan. So this will depend on, when you do the A scan is going to depend on what the clinic preference is. So a lot of clinics actually prefer the A scan performed in the initial stage of testing. So this is before any drops or applanation intraocular pressure is tested, because those tests impact on the corneal surface, and it's better to have an A scan done when the corneal surface has not been disrupted at all. But you would either use your discretion or follow the clinic protocols in this case. But I need to tell you that biometry is something that's done definitely pre-operatively. Dilation is something that's also performed pre-operatively, but this is also linked to the clinic protocols around A scans, because having the pupil dilated can affect the accuracy of the A scan. It also dries out the eyes a bit, and an A scan can really not work well if the corneal surface is dry. Other tests that you'll do is keratometry, and possibly other investigations might include macular OCT or optical coherence tomography or corneal topography. This may require either your clinical judgment or your clinic protocol, so you'll find out what each individual clinic likes to do in the preoperative investigations. Now, if a patient is referred to your clinic for cataract, it may not necessarily be that they'll need cataract surgery immediately. Here are some indications of whether cataract surgery is required. They need an improvement of vision, so surgery is indicated when blurry vision affects their daily living. This is particularly important dependent on their occupation. They have narrow angles, because removal of the natural lens can relieve a narrow angle and help to improve intraocular pressure. If there's a poor fundus view, cataracts can impact on that, and they can be so dense that you actually can't see the fundus. And so, for example, a patient with diabetic retinopathy that needs a fundus check would really benefit from having cataract surgery in that instance. Cataract surgery can also help to lower intraocular pressure in the presence of glaucoma. And there might also be a refractive indication, and you'll see patients requesting what's called Californian cataract surgery, which is where they don't really need a cataract surgery, but it's kind of a cosmetic thing or vision related. They just want an emmetropic refractive result because they have a previously existing refractive error. Indications for cataract surgery in the case of congenital cataracts or in paediatric patients is a little bit different, and the table here gives you some information. So if the child has bilateral dense cataracts, then early surgery is needed up to 5 weeks of age to make sure that the patient does not develop amblyopia. If there are partial bilateral cataracts, then vision is monitored and surgery may be indicated at a later stage. If there's a unilateral dense cataract, then immediate surgery is required because you don't want amblyopia to develop. And then if there's a partial unilateral cataract, then again you monitor vision and make sure amblyopia doesn't develop. So basically, in summary, if the cataracts are dense, whether unilateral or bilateral, they need to come out quickly. So let's take a look now at information about intraocular lenses. An intraocular lens is an implant, and it's synthetic, usually made of an acrylic material, and it's placed inside the eye and it's replacing the focusing power of the natural lens, which has been surgically removed. Usually it's surgically removed as part of the cataract surgery procedure. The intraocular lens is often placed in the capsule or capsular bag, but it can also be placed in the anterior chamber or the sulcus. It creates a state of what we call pseudophakia. So it's not really aphakia because you've got the refractive power or the focusing power being compensated by this synthetic lens. There are many different intraocular lenses available, and each of these has what we call its own A constant, and that means there's a variable power depending on the intraocular lens material and type and so on. Intraocular lenses have actually been around since about the mid-1960s, but the first FDA approval for use in the eye occurred in 1981. Before this, patients remained aphakic following surgery, and you can see there the girl on the top, she's got these very thick glasses, and that's usually what you would see in these aphakic patients. You're really not going to see many of these, if at all, these days, because most people have the intraocular lens now. So initially, an extracapsular extraction or ECCE was performed by surgeons where the lens is taken out whole through a large incision, which was about 8 millimeters, and you can see the lens being actually pulled out there on the bottom picture, and the cataract would have had to be quite hard, grade 3 or 4 cataract, in order to do ECCE or extracapsular extraction, because it needs to come out in its entirety. Over time, though, the surgical technique and the design of the intraocular lenses has been significantly advanced, and now surgeons use a method called phacoemulsification, and this happens through a very small incision, which is only 2 to 3 millimeters and not 8 millimeters like the ECCE. The most recent development in intraocular lenses and cataract surgery is something called the femtosecond laser. And the femtosecond laser, I'll talk to you a bit more about that when we cover surgical technique. It can help to make incisions in the cornea and helps break up the lens as well. So with these advancing technologies, there's really an increased emphasis on the accuracy of the refractive result following cataract surgery, and the orthoptist's role in accurately performing A scans and the pre-operative assessment is therefore crucial. So clinically, you're going to hear about the intraocular lens formula. And what is the intraocular lens formula? Well, basically, this is an algorithm that predicts the power of the intraocular lens that's most suitable for any given patient to achieve a targeted refractive result. And usually the targeted refractive result is plano for the distance. And this algorithm uses the parameters or measurements which are obtained from the patient's A scan. And so it's absolutely crucial that as an orthoptist you are performing an A scan that's precise and accurate. There are lots of different types of formulae available, and the newer fourth generation formulae are actually the most accurate at predicting the post-operative refractive result. And that's because they're better able to predict the estimated lens position in the eye. So the information that they use includes the axial length, the anterior chamber depth, something called the horizontal white-to-white measurement, which is the measurement from one end of the sclera to the other as you're looking at the front of the eye, the iris area, the lens thickness, keratometry, refraction, and also posterior corneal curvature. So this is very, very high-tech information gathering. Previous to these fourth generation formulae, the older formulae may have actually only used 2 or 3 parameters to gain the information. It's things like axial length and keratometry, and corneal curvature was pretty much it. So here's a printout of a patient's A-scan results, and on the very top of the form you've got the formula type listed there, which it says holiday 2, and then the refractive target, which is actually plano. So that's plano for distance. And so what you have to bear in mind is cataract surgery patients, they're usually older, unless it's a congenital cataract, of course, or you're performing surgery on a young child. And so they will be presbyopic. So the target refraction plano is going to be for the distance, and then they'll need to supplement whatever it is that they need for reading. On the left-hand side is the patient's information, and the surgeon is actually listed there. And in a lot of clinics, the protocol is that the orthoptist actually record somewhere on this form as well who's done it, who's done the calculation. So there is some accountability to the orthoptist as well. Next along, you'll see the A-scan data, and the right and left eyes are divided down the centre, which is represented there by the red line, and the right eye OD is circled there in blue, and the left eye is on the other side, on the right-hand side. And so all the measurements are listed there. So the first measurement is AL, which is axial length, and this patient's 23.89 millimetres. The first keratometry reading, the second one, and so on, anterior chamber depth, white-to-white measurements, everything's listed there, the data that the formula uses. Then the next section, the green box, shows the different intraocular lens types used by this particular surgeon. So these are the options that he or she has for their surgery. This is their preference. So the first one is a particular type of toric lens. I'm going to go through toric lenses in a moment. So then you'll see the intraocular power is recommended there, shown by the blue arrow, and it's a 20 diopter lens, which will give the post-operative spherical equivalent of about minus 0.04 diopters. So that's perfect. So you want the patient to be left just slightly myopic rather than hypermetropic, or as close to plano as possible. So some of this might seem a little bit daunting right now, but it's all going to kind of fall in place for you when you go on your clinical placement and you see actually hands-on how this is done. But what's important here for you is to note down this information, to have this at hand and to understand it, so that when you're exposed to it, and you will be, because cataract is one of the leading causes of vision loss, you know exactly what is being talked about in clinic. Now this diagram here shows the accuracy range for current intraocular lens formulae, and it shows the different formulae used to calculate IOL power for short, normal, or long eyes. Now, the older formulae are shown at the top, and you'll see the names Holiday 1, Hoffa Q, SRKT, Haggis, and Holiday 2. So they're the older type formulae. And for example, if a patient is myopic with a long eye, so that's over on the right-hand side, the Hoffa Q formula is actually not suitable for them. So you can't punch in that formula to get the resulting predictive refractive result, and therefore the type of intraocular lens that the patient will require for a patient that's myopic. You can't use the Hoffa Q. You have to use one of the other formulae that are applicable for a long eye, and that might be, for example, a Haggis or a Holiday 2. Now, the newer generation formulae, they're down the bottom highlighted in the aqua green box. You can see Olsen, Barrett, and Hill. And these can more accurately predict the best intraocular lens power to achieve the targeted post-operative refraction. And you can see that they're actually much better at, their range is much better, so they work for short, normal, and long eyes. As I said before, as an orthoptist, you'll definitely be involved in the pre-operative cataract assessment, and you'll hear the term A constant. An A constant is a value which is used to characterize intraocular implants, and it will depend on the location of the intraocular lens. So, for example, the AC, PC in sulcus or PC in bag are the most commonly used options for placing the new intraocular lens, and so the A constant is going to depend on this placement location. Now, this placement location is surgeon dependent, and so the A constant is calculated against each individual surgeon. For now, just remember what the A constant is and how and what it relates to, which is location of where the intraocular lens, the new one, is placed during the surgery. So we're now at the very last little topic for this lecture, and it's the type of intraocular lenses used. You've got monofocal, multi or trifocal, accommodating, non-toric, and toric lenses. The first one I'll tell you about is the monofocal intraocular lens. These have a fixed focus for one distance, and you can choose the post-operative refraction target to be either in the distance or for intermediate or for near vision. Most people will aim for emetropia in both eyes, obviously for the distance, so plano in the distance, and then the patient will need reading glasses post-operatively. A patient can also choose to have monovision, which is where the dominant eye is emetropic and the non-dominant eye is set to myopic, so that they then use their dominant eye for distance vision and their non-dominant eye for reading close up. The patient may also choose to remain myopic in both eyes and need distance glasses, and then they just take their glasses off to read. As a general rule, monovision works quite well for myopic patients, but it doesn't work so well if you're hypermetropic. Multifocal or trifocal intraocular lenses use these diffractive rings, which they're already in the intraocular lens, and they allow the patient to focus for near, intermediate, and distance vision. The patient must be chosen very, very carefully if you're going to use a multi or trifocal intraocular lens. They need to be preoperatively hyperopic, and that's usually the best choice. This is becoming much more popular with technology advances, and what you have is the two different types. So the multifocal one has two focal distances, near and distance, and then the trifocal one has three focal distances, near, intermediate, and far. Now, these lenses do have limitations. They can cause halos and glare at night time. They're not covered by health insurance sometimes, so they can be more expensive. There's an overall loss of clarity of vision, and that's why hypermetropic or hyperopic patients are better suited to these, because they don't mind the loss of clarity, whereas a myopic patient will definitely object to that. And they also don't allow 10 to 20% of light to enter the eye, so you've got a little bit of light loss associated with these lenses too. You might also see patients that have had an accommodating intraocular lens, and the companies that made these claimed that they attach to the zonules and they bend with accommodation, but these lenses have been proven not to actually do what they claim. Now, some patients actually said that their vision improved for reading, but it's not really known why. And these are rarely used now. They were used a bit more around 7 years ago, but you probably will see patients with these, but you won't probably see these used in cataract surgery. And then we've got non-toric intraocular lenses, and most brands of intraocular lenses come either in toric, which corrects for astigmatism, or non-toric, and they can be monofocal, multifocal, or trifocal. So remember, toric lens corrects for astigmatism, a non-toric doesn't. So it will only correct for the spherical power, and you can pretty much only use these if there's less than about 0.4 diopters of astigmatism. There is an online calculator which helps you to decide whether to use a toric or non-toric lens, and you would make that decision when you're performing your A scan and you have your A scan results. A toric intraocular lens does correct for corneal astigmatism greater than 0.4 diopters, and most health insurances would cover the cost of this in Australia. And as with the non-toric lens, there's an online calculator which helps you to work out which type of lens is needed for a given patient. So it's really important that you have accurate keratometry readings, and if the axis is 30 degrees out, the lens will lose all its toric effect. So it really needs at least 2 types of equipment to confirm keratometry, and you need to calculate both the magnitude of the amount and the axis of the corneal astigmatism. And both of these need to agree. So you would probably do keratometry from the optical biometry and also a manual keratometry reading as well, or maybe a corneal topography reading. So you've got to have a couple of different keratometry options that all agree with each other. So what happens in surgery is the surgeon will mark the axis of the astigmatism during the surgery, and you can either do this manually with something called the Mendes dial, which is shown in the middle photograph, or there's also a digital overlay present in the microscope, and then the toric lens is aligned with the marks either on the Mendes dial or on the microscope, and you can see there that the line of the toric matches on the bottom picture in the digital microscope. So some of the limitations are that, or contraindications, is that you need to avoid these on patients with unreliable or unrepeatable keratometry. So if they've got really severe dry eye, epithelial basement membrane dystrophy, ectasia, it's not suitable for patients with corneal graft and so on. A lot of people actually do have greater than 0.4 diopters of astigmatism, so toric intraocular lenses are very popular, so you will definitely see these. So this now brings us to the end of part 1, and so far we've covered the orthoptist role in cataract management. You've been given a basic understanding of intraocular lens formulae, and I've taken you through the different types of intraocular lenses available. In part 2, I'm going to discuss cataract surgery itself, how it's performed, and the complications that can arise in addition to post-operative assessments.